Okay, good. So going back, this was a punch biopsy of a cyst lined by a very thin layer of stratified squamous epithelium with a sebaceous lobule just in the edge of it, but not what we see with the steatocystoma. So it's definitely not the same thing there. And it's got all these little hair shafts in the center. So obviously, you guys probably have an idea of what this might be. This looks like steatocystoma, but it's really not. This is an eruptive vellus hair cyst. So they're also present in multiplicity. They develop in large numbers, and they can be, kind of come up sort of quickly over the course of months or whatever. And they're not always eruptive, but they are present in multiplicity in many cases. And they do have the multiple hair shafts, which helps. And they also have that very thin lining of epithelium. They don't have the features that you would see with, say, a steatocystoma, even though they can clinically look very similar to that. There are some other types of cysts I thought I would just kind of share with you guys. This is another, occasionally you'll see somebody come in with a dark black lesion. You might think it's like a blue nevus or melanoma or something like that. You biopsy it, and it shows the cyst with all these hair shafts that are heavily pigmented. And it can look black clinically or blue. And this also, notice the lining of this is not as thin as the eruptive vellus hair cyst. It's got more of an acanthotic lining, but it has these hair shafts in here that are dark and terminal. And so this isn't really a vellus hair cyst. It's more like a cyst with terminal hair shafts in it, and it can look dark. And there's another type of cyst that's been reported. I couldn't find in the literature. I looked when I did this talk a couple of years ago. Dr. Ackerman reported this probably back in the late 70s in Cutis, I think it was. So it never made it into the, I couldn't find it on a PubMed search, but the name of that cyst was called a chocolate fudge cyst because it looks black clinically, and it has hair shafts in it, but not as many, but it has a lot of pigmented cornified material that almost looks like chocolate fudge when you look at it under the microscope, but it's really keratin that's just heavily pigmented. There's some other situations where you get cysts that have stratified squamous epithelium and other components in their wall. A dermoid cyst, basically this is an aberrant sequestration of ectoderm in the dermis during embryogenesis, and sometimes you can see hair shafts in this also. You can see bone in dermoids, you can see teeth, you can see all sorts of things in a dermoid cyst. So again, here you get smooth muscle, you get sebaceous lobules, you get eccrine apocrine glands. So when you get multiple different components of the hair follicle or adnexal structures, and sometimes even other structures, like if you go to ovarian dermoids, can have all sorts of weird things inside them. So here you've got a sebaceous lobule here, you've got some smooth muscle over here, some blood vessels, you got a hair shaft, a hair follicle that's more kind of a primitive little vellus follicle, and you got the hair shafts inside there. That's a dermoid. Sometimes you get lining with squamous and non-squamous ciliated epithelium. Branchial cleft cysts. Probably ought to know a little bit about this. The board's likely to ask this. Notice the cartilage here. Probably the branchial arch. And then you've got the little cysts here associated with that. And notice it's got kind of a thick acanthotic stratified squamous epithelium around it. Sometimes you'll see other things that are associated with the branchial arches. You know that the parathyroid gland, the thymus gland, the thyroid gland, they're all associated with branchial clefts. And so you can see vestiges and residua of those structures in these cysts sometimes. And they're usually seen along the areas between the midline or the side here behind your ear, or you actually get like a thyroglossal duct cyst that kind of comes out around your hyoid cartilage area, in your larynx area. So that's an area you can see thyroid tissue sometimes. And so here you can see the lymphoid follicles, sort of almost looking maybe like thymus gland a little bit. You can see the cilia, pseudostratified columnar epithelium that's ciliated. That's recapitulating the respiratory epithelium. So that would be a branchial cleft cyst. A bronchogenic cyst. These are found in the neck usually, kind of in the vicinity of the bronchial tree. And again, these are going to be lined by pseudostratified columnar epithelium with a lot of cilia in them. So notice the smooth muscle in the wall there. Here you can see the goblet cells associated with that. And then there are the cutaneous ciliated cysts. These are often seen away from the head and neck area. And again, here you get the lining that's almost looks kind of like an apocrine cyst. When you look at a higher magnification, you can see it's really not apocrine. This isn't really apocrine decapitation secretion. These are little cilia that are lining these epithelium. So important to kind of just know some of these other cysts. And then there's a thing called dermal thymus or a thymic cyst. These are in the branchial cleft area also. And here you'll see little residua of thymus.
I don't think I can see it. I can only see it on my phone.
Why don't you pull over and
With,
switch?
No, it's okay.
Are you guys?
Let's switch. I don't
you
care.
guys-
Just find a spot.
Somebody's. Would you mute your speaker, please? Anyway, here you can see the cyst that's lined by this very thin layer, cuboidal epithelium with the thymus tissue and the hassle corpuscles. So all of those are various types of cysts and things that can develop in the head and neck area. Thyroglossal duct cyst, I mentioned this before, and there you're going to see some residual thyroid tissue. So here you get this little lining here with the columnar epithelium, and then you've got the little small areas of thyroid here, thyroid follicles. So just make sure you know a little bit about those cysts. Again, the pediatric dermatologists like to ask questions about those and anything related to embryology. So if you want to make sure you don't miss those questions. Okay, different situation here. We've got a punch biopsy taken from a hair-bearing area, probably the scalp, and it doesn't look like normal scalp because it doesn't have near enough terminal follicles here. You've got a very dense interface dermatitis with lymphocytes attacking the follicles and the epithelium, the epidermis between the follicles. And that's an important finding because in lichen planus, generally it tends to spare that, surprisingly. You sort of think just a priori that it wouldn't spare that, but it does spare the interfollicular epithelium, and it really targets the follicles. When you see this pattern, and it looks similar to lichen planus in many ways, you should think about discoid lupus erythematosus. And you've also got a little bit of mucin here in the dermis, but it's also got that perifollicular fibrosis, but the inflammation usually goes a little deeper in discoid LE than it does in lichen planopilaris. But there can be some overlap between the two, and sometimes we refer to this as quote, lupus planus, when it has features that kind of look a little bit like lupus and also like lichen planopilaris. And here you can see the thick basal membrane zone with the thinning of the epidermis, which would obviously militate against the diagnosis of lichen planus. Another example here with a lot of follicular plugging. So again, this is chronic discoid LE. And clinically, this might simulate LPP a little bit. This obviously not here with the Carpetac scale and this, scarring and whatnot on the guy's face. But this, in some cases, can be somewhat confusing. And so the best place to biopsy when you're going to try to distinguish one of these is from an active inflammatory lesion. If you biopsy a late stage burned out lesion, you may just see late stage chronic alopecia with not much, it might be able to give you much more of information there. But whenever you see deeper inflammation involved in the epidermis between the follicles with any mucin thickening the basal membrane zone and whatnot, it's more likely to be discoid LE than lichen planopilaris. So hopefully you guys kind of got that. So these are some of the other permanent scarring alopecias that we've talked about alopecia a few weeks ago. So just for review, just make sure you know all these various patterns. And some of the diseases are associated more with neutrophils, whereas others are associated more with histiocytes or with lymphocytes, lupus and LPP, more lymphocytic. We get into things like folliculitis decalvans and erosive pustular dermatosis. Those have neutrophils. And then, of course, sarcoid and infections are going to have histiocytes. Just a couple of other kind of confusing concepts to sort of clear your mind of a little bit. People talk about pseudoplot of Brock. I think that should be a disease. It should be kind of thrown into the wastebasket. It's not really a disease itself. It represents a late stage of lichen planopilaris. Hold on. we'd have to send that for a test. Do that. We can't, but we can do that if we need to. Yeah. Sorry about that. Frontal fibrosing alopecia. Again, I personally think of that as a variant of lichen planus. And then tufted folliculitis, again, is not a disease itself either. It's just a sort of situation. You have multiple hair shafts coming out of a follicle, usually associated with LPP or folliculitis decalvans. We talked a little bit about LPP before. Again, remember, this can give you a very rapid hair loss. It's permanent scarring hair loss. So you want to make sure if you get this diagnosis, you kind of jump on it as soon as possible. Here you can see some examples of lichen planus, and then notice how the inflammation is targeting the follicle specifically, not getting the epidermis between the follicles. That's almost pathognomonic for LP. And frontal fibrosing alopecia histologically looks exactly the same. So to me, it's probably the disease, probably the same thing, just in a different manifestation of it. Here's the horizontal section, which demonstrates the same changes quite nicely. Okay, a shave biopsy here. A lot of purulent crust on the surface. And then we look at the epidermis beneath this, and you've got a epithelial neoplasm. A lot of inflammation here as well in the dermis beneath it. And then you've got these areas with some horn pseudocysts. You've got what looks almost like a seborrheic keratosis, but you've got this big, thick cornified layer overlying it. And then you've got some areas where there's some keratinocytic atypia and some clear staining areas. So this is an example of a squamous cell carcinoma in situ. And one clue to this, the differential diagnosis of irritated SK and squamous cell carcinoma in situ comes up quite a bit on a routine histologic basis. When you see features where you get confluent atypical keratinocytic proliferation over a broad front, that pretty much rules out an irritated SK. And if you get this kind of cornified layer, that's also a sign of malignancy. It's kind of a malignant dyskeratosis. And here you see the clear areas here. So the thing that was the teaching point about this case is this is an example of a squamous cell carcinoma in situ with clear cell features. There might have even been some invasion in there in a couple of areas, but basically you can get clear cell change in a lot of different neoplasms. You can get it in squamous cell carcinoma, we see it in basal cell carcinoma, we see it in melanomas. So clear cell features can be seen in a lot of different neoplasms. Not only malignant, but also benign. So tricholimal differentiation gives you clear cell features. So a lot of different things can give you clear cell morphology. So it doesn't mean too much from a biologic perspective. It's just an interesting thing from a histologic perspective. And sometimes if you get balloon cell changes or lots of clear cell type features, it actually can be somewhat difficult to tell what the entity is. It's got the clear cells associated with it. Occasionally we'll see a melanocytic lesion that can simulate as clear cell epithelial neoplasm. So we may end up having to do special stains to determine that. But just remember that you can get clear cell changes in a lot of different conditions, neoplastic and non-neoplastic ones. Okay, here we've got a shave biopsy of an epithelial neoplasm. It's got an exoendophytic architecture. It's got the verrucous epithelial hyperplasia. And so when you see something like this, the differential diagnosis includes probably about 2 or 3 things. You should think about a wart. It looks pretty bland. It's very symmetrical and doesn't really look very atypical. But also you can get keratoacanthomas that can give you this pattern. And so these can be sometimes kind of difficult to distinguish from one another. If you see atypical keratinocytic proliferation, if you see small cyst-like structures with neutrophils in them, that can favor keratoacanthoma. This little cystic structure here might have been the central crater in a way, possibly. So this could be a KA, could also be a verruca. Sometimes we see this same kind of pattern with prurigo nodularis, and we see it sometimes with hypertrophic lichen planus. So those are all things that are in the differential diagnosis in a situation like this. So you probably would need clinical correlation. This case, obviously, we look at this clinical picture, which is probably not what this lesion looked like, but this was obviously an example of a keratoacanthoma. And we're not generally calling these just keratoacanthomas today. They're generally getting called squamous cell carcinoma keratoacanthoma type, mainly because insurers will not pay anything if you call it a KA. They view that as a cosmetic entity, but these they can behave very aggressively. In many cases, they can just undergo regression, but in some cases, they can get larger and they can even metastasize. And so, I think it's not unreasonable to call call them squamous cell Ka types. Just understand that if you get something like this type of lesion, if you're going to get the eruptive Kas, the Grzyzbowski type, the Ferguson-Smith type, they often look like this. And if you get patients that are taking BRAF inhibitor therapy for melanoma and they develop these eruptive Ka-like lesions, they also look like this. They don't really look like squamous cells. So just because we call them a squamous cell Ka type, you should still think about them as if they were like the old, quote, historic, end quote, diagnosis of keratocantoma. They can sometimes be treated non-aggressively. Treat these with sometimes intralesional 5-FU, intralesional methotrexate. Sometimes you just can D&C them and follow the patients. Just realize that they don't always have an aggressive biology, and you don't necessarily have to do a wide excision or send them to Mohs surgery and that sort of thing. So even though they're getting called squamous cell, just realize that not every single squamous cell is going to have an aggressive biological behavior. Squamous cell in situ, squamous cell carcinoma that arises from solar keratosis, some of those lesions don't really have super aggressive biology, and you can treat those with maybe a less aggressive therapy. Okay, here we've got looks like probably an incisional biopsy, shave biopsy, another epithelial lesion. It's in this, got this verrucous hyperplastic morphology to it. As we go to higher magnification, here we've got a diffuse atypical keratinocytic proliferation extending throughout the entire epithelium here. So this is squamous cell carcinoma in situ. Now, we've seen squamous cell carcinoma in situ, clear cell lesion earlier. Now we've seen a keratocantoma. Now we've got one that's got this almost warty appearance, and it's from an area that's non-sun exposed. So this might be from, say, a genital area. So this case could easily be a squamous cell carcinoma that may have been induced by human papillomavirus. And you can see it's got all of these very large atypical keratinocytes extending throughout the entire epithelium, many mitotic figures. So if we saw something like this from a genital area, we would be concerned about the possibility of an HPV-induced type of squamous cell carcinoma and do HPV typing in many cases. Here you get some clear staining areas of these cells. Again, these look like coilocytes. Someone has labeled that here on the slide. And I agree, they do look similar to coilocytes, so that would kind of favor this being an HPV-induced lesion. So again, you see a couple of examples clinically here. And in this case, this was a in situ hybridization for HPV, which was strongly positive. So probably HPV 16 or 18 in a situation like this. So this was a squamous cell carcinoma that was HPV related. And when you see these lesions, they kind of look like condyloma, and they sort of don't have, from an architectural perspective at least, they don't really look super atypical at low magnification. You go to higher magnification and see some of these changes. That's more likely to be boinoid papulosis. And those lesions actually can behave in a relatively non-aggressive fashion. You can treat those just with a local D&C, or you can sometimes just treat them with imiquimod or even liquid nitrogen therapy. The patient's going to carry the HPV for their entire life. And if they're in a relationship with someone else, well, they need to make sure that they're tested as well, especially if it's a man and he passes it to the woman. The woman's obviously got risk for cervical carcinoma or vaginal carcinoma, so they need to be followed. So I'm sure you all know that, but just remember that HPV-induced squamous cell carcinoma can kind of look a little bit different, give you that kind of verrucous change. It can kind of look like a wart or condyloma on low magnification. Okay, now we've got an inflammatory process, punch biopsy, probably taken from trunk or proximal extremity. So here we see really minimal change in the dermis, and the main change is the cornified layer here. So you kind of have to know what some of the changes are in the cornified layer that can give a black or brownish discoloration. So here you can see that you've got these small granules and very jet black, dark black material on the surface here of coming from outside in. So there's no pigment down here, nothing in the epidermis, there's nothing in the dermis. So this might have been submitted to rule out malignant melanoma or rule out a pigmented lesion, but this is a abnormality in the cornified layer. And so it's dark black. You can see it's refractile. So I don't know if you guys know what the answer is here. I'm not going to, unfortunately, open the chat box up here right in the middle of the screen, so it's kind of annoying, and I'm not going to do that. But hopefully you would possibly recognize this. This is an example of silver nitrate causing a stain, a tattoo, if you will, in the cornified layer. There are several other things that can give you dark color changes clinically that stain the cornified layer. Okay, so you should know those. So in other words, if somebody goes to a tanning parlor and gets sprayed with the material that they spray you with in the tanning parlor, they get a dark coloration of their skin. That creates a little mini tattoo as well. And it's very difficult to see that material on H&E, but it causes a very fine granular deposition in the stratum corneum there also, but it's nothing as intense as you see here. Henna tattoos, you can sometimes see a little bit of staining there, but it's also very difficult to see. So if you see this much of this, it's pretty much classic for something like silver nitrate. And the reason it stains there, it forms a chemical precipitate with the stratum corneum. And so we use that to cause styptic. We used to kind of, when people come into the emergency room or whatever, they'll get a little cut. They'll use liquid nitrogen on there to stop the bleeding. We use Drysol today in a dermatology practice, but they do have the little silver nitrate stick still that you can use in an emergency room setting, and that's used to stop bleeding because it causes coagulation because it precipitates like this. A couple of things that can cause pigment in the cornified layer. Obviously, tinea nigra. You want to make sure that you recognize pigmented hyphal elements in the cornified layer. And then sometimes, very rarely, if you get so-called black dot roost dermatitis, if you're exposed to the actual urushiol of poison ivy, so somebody goes out into the woods and they actually get a big clump of the urushiol on their skin, it can cause a little black tattoo in their stratum corneum. And usually within a few hours after that getting on your skin, it induces a rapid immune response, and it causes basically a neutrophilic infiltrate. So early on, if you get the black dot allergic contact dermatitis from roost, it produces a neutrophilic dermatitis that quickly then changes into a classic spongiotic dermatitis with eosinophils and lymphocytes and whatnot. But just remember that it's very rare, something to encounter, but it does happen on occasion. And then we have terra firma formi dermatitis. That also can kind of give you a blackish coloration to your skin clinically. And we look at it under the microscope, you can see the little small granules in there. So that would be some other things to think about when you get dark coloration in your cornified layer. Okay, here we've got a shave biopsy, epithelial hyperplasia. You've got these little abscesses here within the epidermis, and we've got higher magnification, and you can see that inside these little things here are these refractile structures that look kind of pinkish, and they're actually being transepidermally eliminated through the epidermis here. These are little channels. And here's a nice example of one. So this is a shave biopsy, and you see these little structures here. They're kind of going this way, and they're kind of ending up here in the outside world. So this is a classic example of this entity. Hopefully you guys know what it is. And these are degenerated elastic fibers. So this is elastosis perforans serpiginosa. And in the perforans is a good name because it is actually perforating through the epidermis. And this is what these lesions look like clinically. So of all the so-called perforating diseases, this is probably the only one that's true. The elastic fibers get modified, usually because there's some kind of genetic abnormality. These are often associated with people that have Down syndrome and other things like that. And then they become immunogenic, or they become recognized as a foreign body. And then the host says, well, let's get this out of here. You know, we don't want these degenerated elastic fibers. Let's get them out of our system. And so the idea then is to cause them to be transepidermally eliminated. Now, these other things, like Curley's disease and perforating folliculitis, those are always associated with lichen simplex chronicus. So to get, and usually it's somebody that's got renal disease and they're itchy and they start scratching and they degenerate the collagen bundles there because of the scratching, and then they get transepidermally eliminated. So you really need to have secondary trauma there or you're not going to get the disease. So if you take somebody that's got Curley's disease and they get an automobile accident and they go into a coma and you stick them in the ICU, it all goes away because they have to be rubbing and scratching to make that happen. So this disease wouldn't all go away because this is due to abnormality in the elastic tissue that's probably due to underlying genetic abnormalities. But perforating folliculitis and Curley's disease, that has to be rubbed. So it's a different deal than this entity here. And sometimes we see in patients that have PXE, either from penicillamine or just the genetic variant of pseudoxanthoma elasticum, they can get perforation there also. So those elastic fibers can also be they're not normal because they're calcified, and the body says, let's get rid of them, and it tries to transepidermally eliminate those. So it's very common to see that situation perforating in PXE as well. So these are some of the diseases associated with elastosis perforans cerbiginosa. There's a few. So just remember that these are some of the things that you can see with that, and they're all really kind of related to abnormalities of the elastin and the collagen. So there's a chemical abnormality there. Maybe in renal disease, those collagen bundles get altered because of circulating things from the patient's inability to filter their blood properly. I don't know. Maybe that's why you get more perforating folliculitis in those patients when they rub and scratch as opposed to people that don't have renal disease. But nevertheless, you have to rub and scratch to get perforating folliculitis in Curley's. All right, this is a nice biopsy of this entity here. You've seen a few of these over the last few weeks. So it's something taken from volar skin, and you can see it's got this benign non-epithelial neoplasm, and this is a neural neoplasm. And it's got all of these areas here where you got these little verrucae bodies. And so when we see that, the diagnosis is an Antoni A neurolymoma. So this is a classic example of that. And hopefully, for those of you who looked at the slides, this should be a very obvious example of this for you. And the board exam, if they're going to show something like this there to you, it's probably going to be something just like this, where it's perfect. It's got these beautiful Antoni A verrucae bodies in here. So the neural neoplasms, I'd recommend boning up on those. Know the difference between a neurofibroma, neurolymoma, neuromas. You need to know the difference between like a traumatic neuroma and a palisaded encapsulated neuroma. They might show that. The types of neuromas that you see in people that have multiple endocrine neoplasia usually look sort of like palisaded encapsulated neuromas. They don't look like schwannomas like this. They look a little different. But anyway, just make sure you know those, and pretty straightforward. It's the kind of thing they'd probably show you on a slide. And these are just some of the other items in the differential diagnosis. The Antoni B doesn't have the verrucae bodies. They just have kind of a diffuse area with a lot of mucin, and they're well circumscribed. And you'll often see the pre-existing nerve that led to the neuroma, the schwannoma, the neurolymoma, in a schwannoma as opposed to a neurofibroma. You kind of think about a schwannoma as coming off the sort of the outer edge of the nerve twig, if you will, whereas a neurofibroma sort of comes off in the center of the nerve twig. It's like you sort of went in the middle or just threw a grenade and everything sort of expanded, whereas in a schwannoma, it's coming off the side, almost like a knob on a twig of a branch. So it kind of has two different ways of happening, and usually you'll see the little nerve twig on the edge of a schwannoma if you get enough cuts to look at it. Okay, here we got a punch biopsy, and the action's going on down in the subcutaneous fat. So again, you guys should know how to work through a differential diagnosis of a paniculitis. Is it septal mostly? Is it lobular mostly? What type of cells are involved in the infiltrate? Is there vasculitis or not? And here we've got a largely lobular paniculitis, and we don't see any vasculitis here. And so we've got a lot of these fat microcysts here. We've got some lymphocytic infiltrate, maybe a few neutrophils, pretty non-specific. So it doesn't look like any of the classic lobular paniculidities. It's not lupus profundus. There's no sclerotic fat like we see there with lymphocytes and plasma cells, so it wouldn't fit very well with that. It's not erythema induratum, at least not in an acute stage, because we don't have any granulomatous inflammation, we don't have any neutrophils. So it sort of doesn't fit perfectly with any of the classic lobular, mostly paniculidities when you think about those. So when you see something like that, you might say, well, whenever it doesn't seem to fit, maybe it's traumatic, maybe it's factitial, maybe there's something that doesn't go along with it. You got a little bit of slight amount of membranous fat necrosis here. It's not the same degree that we would expect to see in a classic example of hyperdermitis, but there's a little bit of that. So it says, well, maybe this is related to trauma, some sort of an injury that's associated with it. And indeed, that was the situation here. This was an example of traumatic fat necrosis, and probably related to some prior inflammation that may have been at the site. So again, not any of the classic paniculidities. So the way to work through this one is to go through and do your criteria, apply your criteria, see what fits. If it doesn't make sense, it's just pull back and say, well, you know, this doesn't fit any of them. So maybe it's not in the list of the classic entities. So let's think about things like some sort of traumatic fat necrosis. Maybe it's related to blood trauma. Maybe they got kicked. Maybe it's related to cold. Usually cold will give you some lymphocytes. It kind of looks like deep pernio when you get cold paniculitis in a way. So anyway, just think about that when you're dealing with something like that, and always consider maybe even doing a polarization microscopy. People get pretty creative about factitial things, and they can inject things in there that can make you give you kind of a funny pattern histologically. Now, these are some examples of lobular paniculitis with crystals, and subcutaneous fat necrosis and scleremia neonatorum. We talked a little about this in the paniculitis lecture a few weeks ago. They both look the same, but basically these guys have too much palmitic acid in their fat, and they get these little crystals that precipitate shortly after birth. So when you see crystals sitting inside the lipocytes, like here, think about subcutaneous fat necrosis of the newborn or scleremia neonatorum. They're probably the same disease, just different stages of severity. And so I always like to lump when everything looks the same histologically and they sort of have a similar biologic behavior. And some of the patients with subcutaneous fat necrosis get better and they do great. The scleremia patients maybe do worse, but it's probably because those kids are sick from the beginning. So I'm not sure that the disease is worse. I think it's probably that the kid is bad. So in this situation, just if you see these crystals inside there, think about these diseases. So to me, they're probably both one and the same. So here's another example. They can sometimes get hypercalcemia associated with these conditions. We associate it with the mother is often sick when they get these, and the mother may have been using a drug. So just remember that basically they're lobular paniculitis with crystals inside the lipocytes. Okay, here we have it was a deep shave biopsy, and it's got this marked verrucous epithelial hyperplasia. And this was on, sorry about the picture here, it didn't come out very well, but it was on the lip, and it shows all this verrucous epithelial hyperplasia here, okay? So here's another example. So it looks like a wart, okay? It looks warty, but sometimes warty verrucous epithelial hyperplasia can be a reaction pattern. And there's a lot of different things that can give you verrucous epithelial hyperplasia. That's not a wart. So again, we talked about keratoacanthoma, warty verruciform xanthoma. Looks warty, but it's a xanthomatous reaction pattern where you get xanthoma cells in an area like here. We don't have any of that in this situation. It's not a verruciform xanthoma. Pseudoepitheliomatous hyperplasia can give you warty verrucous epithelial hyperplasia. Sometimes even psoriasis can give you verrucous change. So lupus, a lot of things give you verrucous hyperplasia. So when you get this situation here with all these neutrophils in the cornified layer and the verrucous hyperplasia near the mucous membrane, you should always think about the possibility candidiasis. And here you see, even with an H&E, you don't even need a PAS stain. It's got all of these hyphal elements or pseudohyphae that are just penetrating the epithelium here with all these polys. So this was an example of verrucous candidiasis. I'm not sure these pictures really are that. Generally, when you see verrucous candidiasis, it's more of a verrucous epithelial hyperplasia. It can look like a wart. In this case, they said it was an actual wart with candidiasis. Maybe it was. But you can get verrucous hyperplasia just from the candida. And when you see that, what you should do is, number one, make sure that, because sometimes the verrucous hyperplasia can look atypical, you don't overcall it as a squamous cell and then wipe out somebody's lip, and then it all comes back because the candida has not gone away. So what you really want to do in that situation is treat the candida, see what's left. If it's still got a lot of verrucous epithelial hyperplasia at the end of treating it after, say, 6 weeks or so, then maybe take another biopsy to make sure you're not dealing with a real cancer that's maybe secondarily infected with candida. But you don't want to just call candidiasis with verrucous hyperplasia with atypia a squamous cell right away, because that's really a serious situation. And you can end up leading to serious deforming surgery when it may be from an inflammatory process. So just remember that you can get very atypical keratinocytic proliferation with candida, and it's not a cancer. Okay. All right, here we've got a shaved biopsy, and we've got an epithelial neoplasm here. Notice that it's got this exoendophytic morphology to it. Okay, we're going to look at this change now down in the dermis, and it's got all of this acantholysis and also dyskeratosis. So hopefully, for those of you who are third-year residents, this would be something that would instantly trigger the differential diagnosis of the acantholytic dyskeratotic conditions. And hopefully it's kind of a review for you, because there's about 5 or 6 things that can cause it. And when you see it at this power, so if I were writing a board examination and I really wanted to try to be mean, I would probably say the differential diagnosis pattern includes, and I would probably put Grover's disease. You might put Haley disease. You might put Darier's disease. You might put solitary keratosis, solitary acantholytic dyskeratotic keratosis, and then you put Warty Dyskeratoma, all of which can get acantholytic dyskeratosis. And then you'd have to say, well, I'm going to make the diagnosis based on the fact that it's got this architecture that looks like a cyst. And that's how you would do it in the real world anyway, even if you weren't doing a multiple choice question, because you would want to basically use the architecture, use the fact that it's a solitary lesion, use the fact that it's usually on the head and neck area, and just know that the lining looks like acantholytic dyskeratosis, and then you would be able to make a specific diagnosis of this. So you shouldn't, in something like this, put in everything that causes acantholytic dyskeratosis. If you want to do that in a grand round situation to impress the attendings that you know every disease that can do that, that's fine. But we're dealing in the real world, you want to get a specific diagnosis. And none of those other things would give you this. So this looks like a cyst. It's got acantholytic dyskeratosis in it. So the specific, correct, solitary diagnosis is this. And probably the one thing that of these various things in the differential that would be the most important thing would be an acantholytic squamous cell carcinoma. And those generally, again, do not have an architecture. When you get a nice biopsy like this, which if you're on a board examination, that's what they're going to give you, by the way. They're not going to give you a shave or something. So you would never see that kind of architecture in an acantholytic squamous cell carcinoma. It's going to have asymmetrical features. When you go to higher magnification, you see mitotic figures. You may get some acantholysis, but you don't get acantholytic dyskeratosis in this pattern here. So you should be able to tell those apart also. So they might put that in there on a differential diagnosis on a multiple choice for on your exam possibly. You should be able to recognize those from one another, distinguish them from one another. Okay, this case was kind of difficult because when you look at it low magnification, it really looks pretty epithelial-like. You say, well, gosh, maybe it's a pigmented basal cell. I mean, there's some pigment in here. But you go to higher magnification, it's got this change. It's got these single cells at the basal cell layer here and some cells above it with the melanin. And then you look at this zone over here and you've got a lot of melanin in here. And this is more of a cautionary biopsy, if you will, because this looks pretty epithelioid. It's actually, in this case, a malignant melanoma in which there is some necrosis en masse. But if you just look at this, you could confuse that with a pigmented basal cell. And malignant melanoma can sometimes look pretty epithelioid. So just remember, and I've seen that diagnosis missed a number of situations. And in a shave biopsy situation, it's not, sometimes you miss the diagnosis of a pigmented basal cell and a malignant melanoma. They can sometimes look similar under the microscope. So just remember that even though it's usually not that hard to tell them apart, in some cases it can be difficult to tell apart. So this was an example of malignant melanoma. It had an area of necrosis. I think that was what the fellow, when he chose the slide, really wanted to show here. I would say that if you want to think about something that's almost always true, if you get a melanocytic neoplasm that's got any atypicality to it at all, and you're kind of struggling between an unusual nevus and a melanoma, if you see necrosis en masse, that's almost like a trump card, a joker in poker, if you will. If you get that, it just pretty much makes it melanoma. There's almost nothing that will give you necrosis en masse in a melanocytic lesion other than a melanoma. And so if you're dealing with like an atypical usually the question is an atypical spitzoid lesion versus melanoma. If you get a necrotic area that's pretty significantly necrotic, not just a few cells, but necrosis en masse, it's almost always melanoma. And that's almost always associated with ulceration too, by the way. So anyway, that was an example of a malignant melanoma. And I think probably the more interesting case thing there is a sort of simulated a basal cell. This is kind of epithelioid a little bit. Okay, now hopefully you're able to recognize this is a longitudinal nail unit biopsy. Beautiful example of that. So whenever we get something like this, it's just really, it makes our day as a dermatopathologist, because usually when we get nail biopsies, they're small punches and they may miss the matrix and all, but here you're getting stuff that goes all the way back to the proximal matrix. So if you really want to diagnose a melanocytic neoplasm, that's what you really need. You really need to get back to the matrix. If you biopsy the distal end of it, obviously you run the risk of not even getting a melanocytic lesion there at all. And here we have some nail plate. We've got some epithelium here, and we've got cells within the nail plate that are melanocytes, and they're scattered diffusely here throughout the nail plate. That's a red flag. We see something like this, even though it's hard to tell based on this what's going on, we would be very, very concerned about melanoma. So this is a good clue. If you see melanocytes within the nail plate that are relatively large with clefts surrounding them, that's almost always melanoma. If you see columns of melanin, small columns of melanin though, that's almost always benign. That favors a lentigo as opposed to melanoma. So something like this, even though we don't really have much going on in the epithelium in this field, would make us very concerned about melanoma. Now here, we do have the proximal nail matrix, which was taken by that excellent longitudinal nail biopsy technique. And you can see that it's got these large melanocytes at the dermoepidermal junction, and you've got a few cells above it, okay? And sometimes when you biopsy these melanomas of the nail unit, they don't look like florid, obvious melanomas with cells throughout the epithelium. Sometimes you'll see this kind of change alone, or you'll only see dendritic melanocytes with dendrites that extend high up into the epithelium. And that's very important, very helpful when you're diagnosing melanoma in the nail unit. And so we will often do SOX10 stains, we'll do Fontana-Masson, looking for these prominent dendrites that extend high up into the epithelium. Unfortunately, we don't have a higher magnification view here, but you can see there's a dendrite right there. There's another part of the dendrite way up here. You don't get that in simple lentigines in the nail unit. So if you see that, it's involving melanoma of the nail unit. In the discussion. You don't have to move any further. And it's very common in these lesions on the nail unit. You kind of get kind of an inverse Christmas tree type of pattern. You get like approximately, usually extends more widely than at the distal part. This isn't a very good example of that, but you'll often see that. melanoma in situ of the nail unit. So if you get one pigmented band, that's a red flag. The thumb is a common location. That's a red flag. If you get that sort of Christmas tree pattern, that's a real red flag. And then make sure you take a good biopsy, and you got to get back to the matrix. So the other thing is about pigmented nail unit lesions. If you biopsy like a racial pigmentation, for example, or just a simple impetigo, it may have just a very, very subtle, it looks a lot worse clinically than it does histologically. And we almost always stain those up, and the number of cells can be very, very few there. So you really need good clinical correlation. I would recommend, number one, never send that to a general pathologist. So if anybody general pathologist is listening to this, I don't care, because you don't see enough. You need to see a lot of these. And these are tough. They're medical legally charged. They're difficult to diagnose. They don't get good biopsies. Even if you get a good biopsy, they don't always show classic findings. So you need to have a lot of experience with this. This isn't something you want to be a cowboy on. You need to get somebody that's looked at a lot of these to make a definitive diagnosis. And I would recommend getting a clinical photograph every time. So this is one where you always need a clinical picture, and you need to have expertise at looking at it. If you don't, trouble will brew. So just remember that when you're dealing with pigmented nail unit lesions, they're challenging, and you need to know what you're doing. Okay, punch biopsy here. It looks like it's from an area where there's a lot of big, thick, dilated blood vessels up here. So stasis altered skin. There may be stasis change all the way down here. So this might even have a component of what we might even see with acroangiodermatitis, but you've got these really large ectatic blood vessels with this fibrin in their walls, and maybe even some fibrin in the lumina, and then all this prominent stasis change here. You've got some inflammation, some spongiosis. So you can imagine this person's probably got stasis dermatitis. And then you start looking here, you've got all this fibrin in these blood vessels. So hopefully you all are able to recognize this as Atrophie Blanche, lividovasculitis, a classic example of that. These are the stasis changes down here. This guy probably had acroangiodermatitis, horrible stasis change. And you can get variable degrees of inflammation in lividovasculitis. Sometimes you get neutrophils, sometimes you get a little nuclear deaths, but a lot of times you get nothing. You get just this kind of change, which is mostly fibrin. And the pathophysiology of this disease is the loss of fibrinolytic activity due to the ischemia from chronic stasis change. So they lose their fibrinolysin. It goes away. So they don't have the enzyme anymore. So the fibrin just deposits. Normally it probably deposits in all of our skin every day, but we have enzymes just wipe it out and it makes it go away. And these people, they don't have the enzyme anymore because it's ischemic and there's not enough of it. So the fibrin just keeps depositing, eventually it chokes off, and you get blisters, you get the porcelain white atrophic areas that develop at the end, the cribriform change that you see here. So this is a classic example of Atrophie Blanche. And that can be associated with either stasis change, stasis-associated lividovasculitis, or with a connective tissue disease. So you're obligated to make sure that the patient doesn't have lupus or something like that if they have that. The vast majority of cases that we see do not have a clinical disease associated with it. It's just bad stasis, and they just get this. And unfortunately, this does not include the best therapy, which is Plavix, or one of those drugs. I've had many patients I've treated over the years treated with that it just does beautiful. It's almost like a Plavix deficiency. So if you ever get a patient with this, strongly recommend, I would forget about this. This stuff doesn't work. It's lousy. Plavix works so much better. I've only had about 1 or 2 patients in 20 years that didn't respond to it. So highly recommend that as a treatment for that disease. And the other thing is, if you get a stasis ulcer, if you have sections, you're probably going to see some areas of thrombosed blood vessels with fibrin. So stasis ulcers pretty much should be treated with that as well in many cases, I think. Okay, we've got one final case. You've got an interface dermatitis here, superficial and mid-perivascular infiltrate, but notice you've got this dense band-like infiltrate, lymphocytes, extravasated erythrocytes, parakeratosis, confluent parakeratosis, containing neutrophils in the cornified layer, possibly in a couple of areas, and then some individual necrotic keratinocytes here. So this is a classic, beautiful example, every feature you'd like to see here of pityriasis lichenoides. And you can see the dyskeratotic keratinocyte there, extravasated erythrocytes over here. Now, is this pityriasis lichenoides a varioliform acuta? Is it subacute? I don't know based on the histology. It looks pretty good for the acute form, but you know, a lot of people that have this may have it for years. And people that have one of the reasons I don't like using the name acute and chronic in the diagnosis of diseases by their name is because patients that have pityriasis lichenoides chronica, they may pop up with an acute lesion one day. And you biopsy that and it looks like classic pleva, but they've had the disease for 15 years. So that's why I don't generally like using the term acute in a name, like acute lupus erythematosus. We get patients that may have SLE for years. And they may be a chronic disease. So anyway, this looks histologically pretty good for pleva. There's a lot of different forms. Obviously, there's the type that can be very serious. You can get the febrile illness, end up in the hospital, the ICU. You can get the type that's more chronic. You just get these individual papules that come and go for many years. But it gives you this classic interface dermatitis with lymphocytes, the extravasated erythrocytes, the perikeratosis. It's a wafer-like scale. It's not branny. This stuff is scale crust with neutrophils. And these things are crusty. They don't look like the same scale of psoriasis, for example. The scale looks different than it does here and than it does in tinea versicolor and whatnot. So just looking at the scale alone, you can suspect the diagnosis of this entity just looking at that. So it's a helpful histologic clue. And you really can't tell just looking at the individual lesion what stage of evolution they are in their disease. So anyway, that's pityriasis lichenoides. And I hope you guys enjoyed the session. For you third years, good luck in your career. Good luck on the board examination. I know you're all going to pass. For you second and first years, I think we're going to skip next week. And I think the following week, we're going to have kind of an intro to dermatology lecture. You're more than welcome to join and learn about what's so great about dermatology. And I hope you guys enjoyed the lecture and good luck to you guys in the future. Hopefully we'll be seeing you at board reviews and things of that nature. We do have a board review coming up this coming weekend for you guys who really want to bone up on your pathology. And I'm going to be giving a session at 7 o'clock tomorrow morning. Early risers, join us. And we'll learn more about DermPath tomorrow morning. Take care and have a great weekend.